Good morning, and thank you for participating in this panel around the question of the social accessibility of mental health. My name is Marianne Schulze. I'm a board member of the Global Initiative on Psychiatry, and I'm thrilled to see this conference come together and to be able to contribute to an issue that's very dear to me, and that is the question of how accessible or inaccessible is mental health, our mental health services for users and importantly also survivors um, of psychiatry. When we think of the term accessibility, we frequently think of the physical dimension, and more we're also discussing the communication angle of accessibility. What's not yet so much in focus is the question of how accessible, are services generally from a discrimination point of view. How far do stigma and other factors in human interaction play into how safe, how comfortable, how welcome people feel in accessing institutions, in approaching services. And from a human rights perspective, I'd like to start that discussion from a quote that I think is quite famous for human rights, and that is the non-discrimination clause in the Universal Declaration of Human Rights, which says that all human beings are born equal in dignity and rights, and continues to say everyone is entitled to all the rights and freedoms set forth in the Universal Declaration without distinction of any kind, such as race, color, sex, language, religion, political or other opinion, national or social origin, property, birth, or other status. The Convention on the Rights of Persons with Disabilities reminds us of the fact that there are many aspects that are parked under the notion of other status. We might come back to that in a little while, but for starters, if we want to heed this call that everybody should be equal in their dignity, in their enjoyment of rights, or in different wording that everybody, all human beings, should feel welcome, should feel safe. What does that mean in the application to institutions, to medical institutions, and specifically to mental health institutions? We need to ask ourselves some hard questions as to which perceptions that are dominant in society at large, which images of persons play into barriers that we build into the way we plan our programs, in the way which we design our policies, in the way in which we operate our mental health units, our citizenship application office, any given institution. How do we make sure that these distinctions that the Universal Declaration alludes to here, and that are then also packed into the notion of other status, how are they reflected, or how do we address a possible discrimination or a possible differentiation in treatment in our daily interactions with people? Just to help us understand a bit better what could be added to this list under other status. It's a very evolving list, as one can imagine. We now also include marital and family status, disability, of course, and depending on the geographical context, sexual orientation, or economic and social status, and obviously, not least as a result of the pandemic, also health status is becoming more and more a feature in consideration for the denial or the accessibility from a non-discrimination point of view. What we need to take into account as we talk about social accessibility is the concept of multiple and aggravated forms of discrimination, as also enshrined in the Convention on the Rights of Persons with Disabilities. And I have here a quote from a report of the Fundamental Rights Agency that brings that home in a very pointed way as applied to the medical profession, where several healthcare providers in each of the EU member states were reluctant to talk about the possible existence of discrimination in the healthcare sector, emphasizing that the universalism of healthcare associated with the Hippocratic Oath would sort of, in a way, prevent the existence of such excluding factors in that institution. As a human rights advocate, I would like to suggest that practices of discrimination, the prevalence of stigma are widespread throughout society across all social strata, and nobody, unfortunately, is immune to excluding others on one ground or multiple grounds. But the idea that somebody is excluded not just on account of their health status, but possibly also because of their economic situation, because of their ethnic background, maybe because of the display of actual or perceived religious symbols. All this plays into how we treat people, how welcome they feel, and whether or not it results in an interaction and possibly, legally speaking, also in a non-action in interaction with people from all walks of life. There is also very specific settings, or the differently put, the mental health setting is a very pronounced one where a lot of exclusion factors are put onto a very, very special lens. And I'd like to very briefly touch on a report by the first Special Rapporteur on the human right to health, Paul Hunt, who's now the Human Rights Commissioner of New Zealand, who brought a few examples in the context of harm reduction of how, particularly in the mental health sector, there's a lot of discrimination, a lot of exclusion ongoing. One example being an ambulance refusing to come to the rescue of somebody who had a drug overdose because the perception is that the underlying activity is perceived as illegal. There are countless examples, and I'm sure a lot have already been discussed in the context of the conference. So let me maybe highlight one other setting that from a human rights perspective needs emphasis, and that is that of prison settings. The exclusion that is cemented in the walls behind which prisons act, or in which prisons are institutionalized, makes special human rights scrutiny necessary. And I would like to highlight the idea by the Special Rapporteur on Health, who emphasized that on account of the fact that prisons are as excluded and secluded as they are, we might actually need to double our efforts and apply what we call positive discrimination, that is, go beyond what is necessary for mainstream society in order to meet the needs of people that are in particularly excluded settings such as prisons. One might also want to think of very highly restricted mental health institutions in this kind of dimension. The importance is to appreciate that we are under an obligation to deliver the minimum standards that we apply in society at large, at the very least, to these closed institutions, but that on account of the barriers that are inherent to such institutions, we might actually need to go the extra mile in making sure that a sense of balance, a sense of safety and a sense also possibly of inclusion is applied in these contexts. With that, I'd like to briefly come to some of the core messages from the Convention on the Rights of Persons with Disabilities, which essentially says fix society, not people. And I would like to remind us that the Convention enshrines the fact that disability is an evolving concept, and more important to the question of social accessibility, that impairments interact with attitudinal and environmental barriers, and that social accessibility definitely falls under the notion of an attitudinal barrier. Furthermore, please be reminded that the non-definition in the Convention of Disability, there's only a description included on those who have a long-term physical, mental, intellectual, sensory impairment, that in interaction with various barriers, and that includes social, attitudinal barriers, hinders the full and effective participation of persons with disabilities on an equal basis with others, again reinforcing this need to reflect on our practices and policies with regard to social accessibility. The discrimination clause in the Universal Declaration that started my presentation is now supplemented in the Convention on the Rights of Persons with Disabilities, both including the concept of multiple and aggravated discrimination. Indigenous peoples have been included. Age has prominently been included. That is not found elsewhere in any other United Nations human rights document to date. And again, other status, which is evolving, expanding, has been added there too. Let me also try to very briefly highlight the various dimensions of accessibility. I said at the beginning that I see the social dimension as the most important one practically in reflecting on how we approach and include people. But obviously there is communication areas that are quite well known for deaf people, for people with visual impairments, that there's also the necessity to accommodate intellectual impairments and to ensure easy to read formats. Important here to highlight that these easy to read formats not only serve persons with intellectual impairments, but are generally more user-friendly and address also the needs of functionally illiterate people, people with a minimum uptake of the local language, and obviously also people in distress who might have a limited capacity at that very moment to process information. Economic accessibility is another word for affordability, issue that's always been pressing in the mental health care sector, but has become even more pressing in the course of the pandemic, and now the general economic disruption, the growing inequality. The physical accessibility is one that I think is the most familiar, with the need to replace or avoid staircases and to ensure a certain width of rooms and doorways. And lastly, institutional accessibility, to really ask ourselves these hard questions as to how do we exclude certain people, how welcome do we make people as they access our institutions, how safe can a person feel when they use our services. Those accessibility angles can be very helpful in jumpstarting those conversations around making sure that our processes and institutions are truly approachable and usable for all. Lastly, I'd like to give us a bit of perspective as to how we compare our current approaches to those that we want to develop based on the Convention on the Rights of Persons with Disabilities. And I'm quoting Dr. Patricia Deegan here, who says, have we embraced the concept of the dignity of risk and the right to failure? Chronically normal people or people who have not been psychiatrically labeled allowed to make dumb, uninsightful decisions all the time in their lives. My favorite example is Elizabeth Taylor, who just got her 8th divorce. We might say she lacks insight. She's failing to learn from past experience. However, when she embarks on marriage number 9, no SWAT team of nurses with Proxylin injections will descend upon her in her best interest. To reflect on the fact that we all sometimes make decisions that are hurtful, harmful in a way, but not necessarily at such a degree or such a level that warrants the very harsh and limiting, if not to say violating boundaries that are sometimes set. And this concept of dignity requiring us to fail, requiring us to take risks, is one that one should embrace, not just as a general notion, but particularly when questioning one's policies and approaches in ensuring that they become more accessible in all these multiple dimensions. As a quick wrap-up, a reminder that when we talk about ensuring the consent of persons, particularly in the mental health sector, we need to make sure that there's not just the legal capacity that's in the books, but that there's the right to act, that legal capacity. If we want to assume that there are phases of incapacity, we need to absolutely minimize those and be sure to return to an assumption of capacity as fast as is possible and engage in some kind of reconciliation, some kind of recovery, and ways forward that fully engage the person, fully engage the premise that that person has capacity and has a right to act that capacity. And as a very last thought, a couple of other provisions in the Convention on the Rights of Persons with Disabilities that relate to social accessibility. It's a selection in the interest of time, but to remind us that there's an obligation to consult persons with disabilities as experts in their own right, in accordance with Article 4, number 3, that there is an obligation to provide and enable reasonable accommodation, and that especially women and children receive special protection within the framework of the Convention. And obviously, there is, among others, a right to health, the right to rehabilitation, and related provisions that all reinforce the importance of making sure that policies and services are socially accessible. And with that, I'd like to thank you for your attention.